Dear colleagues, welcome to today's EHRA webinar on acute coronary syndrome and atrial fibrillation, triple or double anticoagulation therapy. My name is Jan Steffel from the University Hospital of Zurich, and I have the great pleasure of being joined by Dr. Story from Sheffield and Dr. Byrne from Dublin. Welcome.
Thanks, Jan. Thank you.
Terrific. Well, the aim of this webinar is to give you a better understanding of the management of a very difficult to treat patient population, that is, patients with atrial fibrillation and an ACS and or undergoing PCI. And we'll do that through clinical case presentations. This session is interactive, and we strongly encourage you to actively participate by sending your questions and comments through the chat at any time during the webinar. For the best learning experience, we also invite you to test your knowledge by answering the multiple choice questions that we will put up during the webinar. Now, this webinar is supported by Bristol Myers Squibb and Pfizer in the form of an unrestricted educational grant. The program is not influenced in any way by its sponsors. And before handing over to the case presentations, I will start with a little bit of a brief overview and get us started on the topic. These are my personal disclosures. And when we talk about the patient population, those patients with atrial fibrillation who also have an ACS or who have to undergo stenting, we're faced with a situation where on the one hand, we require antiplatelet therapy or possibly dual antiplatelet therapy after PCI or after an ACS. On the other hand, where we require inhibition of some kind of the plasmatic coagulation cascade by vitamin K antagonists in the old days or by the NOACs nowadays. Now, we used to view these two parts of the coagulation, plasmatic on the one hand, thrombocytic on the platelet on the other hand, kind of as dichotomous, kind of as one after the other, not really having to do much with each other, which in fact was an oversimplification. Because as we can see in this sketch here, there's actually many ways in which, and many parts in which they interact. These are highly interwoven. So the question then comes up, what do we do with these patients? On the one hand, they need antiplatelet therapy. On the other hand, they need plasmatic anticoagulation. Do we have to go with triple therapy for all of them? Do we have to give them triple therapy for 1 year? All of them, which was kind of the standard of care 10, 15 years ago? Well, the question was already complicated prior to the era of NOACs. Now, for over 10 years now, we've had the NOACs available, and with their advent, we had another problem because we also didn't have any data for NOACs in that context. Well, this has changed over the last couple of years. As you know, there are now 4 studies that are all out that have dealt with this. The Pioneer AF PCI trial with rivaroxaban, the Redual AF PCI with dabigatran, the Augustus AF PCI with apixaban, and just recently published and presented at ESC, the Entrust AF with edoxaban. And these trials have really helped us understand a lot better, which patients we're dealing with, what the event rates are, and how NOACs plus or minus single or dual antiplatelet therapy behave in that context. And with that in mind, we have also, we will be updating, guidelines will be updated, our EHRA practical guide will be updated at one point in time. In the last iteration of 2018, this is what we came up with in terms of recommendations for the setting of AF patients either undergoing elective PCI or with acute coronary syndromes. And as you can tell, there are 3 concepts to keep in mind here. Number 1, triple therapy is really reduced to a much shorter duration as compared to previous iterations. For elective PCI, we at the time, and that was in March of 2018 when this was published, recommended only for a couple of days triple therapy after elective PCI, followed by dual therapy. After ACS, we recommended 3 months of triple therapy. Now, the second concept you can see here is that there is a huge potential for individualization, as indicated by the green and the red arrows, so that there's really no one-size-fits-all scheme for all patients. And the third important concept is that after 1 year, for the majority of patients, we can actually go with NOAC as a monotherapy. Well, this is what we recommended back then. Since then, we've had the Augustus trial and we've had the ENTRUST-AF trial. So new data, new possibilities. And with this, I would like to hand over to Professor Story, Rob, for your presentation, and we're looking forward to that.
Great. Thanks very much, Jan. So great to be here and talk about this exciting topic. We've got this evidence with some limitations and a lot of consensus, but different opinions. So I'm going to present a case which encapsulates some of the challenges that we have now. Firstly, my disclosures, which include a number of different companies relevant to this talk. So my case is of a 72-year-old female admitted with non-STEMI to a local hospital. Previous history of stent to the LAD 4 years ago for an anterior STEMI. History of permanent atrial fibrillation treated with apixaban 5 milligrams BD, and a history of type 2 diabetes treated with metformin, and hypertension with systolic blood pressure of 162 millimeters mercury on admission, so evidence of it not being suboptimally controlled. ECG confirms AF, an anteroceptal Q wave formation, as well as infralateral T wave inversion, which seemed to be new. So she was started on aspirin and ticagrelor, and we can debate about whether you should start a P2Y12 inhibitor in this case, but fairly good indication that PCI may be necessary. And this was prior to transfer to a heart attack centre, so sometimes in the UK there's a bit of a lag between transfer to the heart attack centre. CHAS-VAS score of 5, so high thromboembolic risk, a HAS-BLED score of 3, so getting into the sort of higher risk bleeding category. Coronary angiography was performed and showed occlusion of the previous LED stent. And on the right coronary artery, we see severe disease as the culprit for her presentation with non-STEMI. Now, we don't usually do left ventriculography, but in this case, it was helpful to look at this, to look at potential evidence of viability. And this showed a dyskinetic anteroapical segment consistent with a completed infarct in the LAD territory, as was suggested by the ECG. So, despite this, opinions were taken regarding CABG surgery versus PCI, but in view of the fact that the LAD territory did appear to be infarcted and the left coronary vessel generally looked poor for grafting, the decision was taken to proceed to PCI to the right coronary artery in the first instance. So PCI was performed with a drug-eluting stent, 38 millimeters in the mid to distal right coronary artery, and then a further stent, 34 millimeters in the proximal artery. And this achieved a good result, evidence of well-deployed stents throughout that segment of artery, good diameter after post-dilatation, and good flow to the distal vessels. So the question now is, what do we do with the antithrombotic therapy? Do we stop the aspirin or continue for 1 week, 1 month, 3 months, 6 months? We have all those potential options supported by trials and evidence and guideline recommendations. And do we switch ticagrelor to Clopidogrel? And is this influenced by what we decide to do with the aspirin? We have the results of Augustus to give us some steer on this. So Augustus was 4,600 patients who were randomized 2x2 factorial to apixaban or VKA and aspirin or placebo. And in the comparison of VKA versus apixaban, there was significantly less bleeding with apixaban versus VKA, highly significant. Similarly, comparing placebo with aspirin, there was considerably more bleeding with aspirin, number needed at harm of 14. So no doubt if you stop giving aspirin to these patients after PCI when they're stable, then you can dramatically reduce the risk of bleeding.
Now, Rob, remind us again, this is all on the background of clopidogrel or P2Y12 inhibitor therapy for all patients, right?
That's right. So patients all had to have planned use of a P2Y12 inhibitor for 6 months. And that was part of the strategy for the 6-month study and allowed this randomization to aspirin or placebo. But what about ischemic events? And this is particularly interesting when we compare aspirin versus placebo. So there was no significant difference in death and ischemic events between the groups, numerically less in the aspirin group. But when we look at definite or probable stent thrombosis, there's clear evidence of numerically fewer in the aspirin versus placebo group, but it's not statistically significant, indicating a lack of power for the study to show significant differences between aspirin and placebo for this particular endpoint. So it leaves some uncertainty. We have this numerical trend. It's not statistically proven that you need aspirin, but still a strong suggestion that you might, at least in some patients. So what are the components of stent thrombosis risk that are going to guide us in terms of deciding on therapy? Well, when we talk about stent thrombosis risks, there's really two components to this. One is the risk of stent thrombosis actually occurring, and the second is the risk of death should stent thrombosis occur. So risk factors, some of which relevant to this patient, of stent thrombosis actually occurring at age, the length of stenting, ACS, type 2 diabetes, and occlusion of the previous stent. In terms of the risk of death, well, we've got, again, age as a factor here, but also left ventricular systolic dysfunction due to the previous LAD territory infarct. So quite a number of risk factors there related to stent thrombosis. What about the cardiac thromboembolic risk? In terms of CHAS-VAS score of 5. And you note that now there's a move towards including any vascular disease in the point for vascular disease history. And has-bled score of 3, as I'd said, and here risk factors for bleeding including age, female sex, and hypertension with recent suboptimal control. So a number of different factors to consider there. Now, in terms of coming to a decision about the pharmacology, one of the questions is what is the role of thrombin in thrombosis? Because the anticoagulants are targeting thrombin formation and or its action. So here's a question to you. Does thrombin A, play no direct or indirect role in platelet activation? B, only indirectly activate platelets via leukocyte activation? C, only indirectly activate platelets via fibrin formation? D, directly activate platelets via protease activated receptors? And E, directly activate platelets via P2Y12.
All right. Now, as answers are coming in, we have another 10 seconds. I was saying this earlier. Who of you learned in medical school that these are two separate entities, one coming after the other? Primary hemostasis and then coagulation afterwards.
Yeah. I think there was, for a time, we did tend to look at these as separate systems, realizing that maybe there was some backward interaction, but I think more and more we're beginning to realize this complex interplay, which you highlighted nicely in the introduction, and I think this is kind of the point of Rob's question here.
Yeah, and Rob, I think there's room for education in that regard, because we really have almost a thirds split here between the 3, 4, and 5. Answer number 3, 4, and 5. So please enlighten us.
So, well, you did give a clue on your earlier slide. So, actually, platelets do have protease-activated receptors that are receptors for thrombin. So, thrombin directly activates platelets via these receptors, PAR1 and PAR4. No impact on P2Y12 receptors of thrombin, although thrombin activation leads to ADP release, which activates P2Y12 receptors. And there is a role for thrombin in inflammation. And also this interaction between platelets and fibrin formation. So it is all very intricately linked. And even the coagulation cascade is no longer linear. So even that's confusing by itself. And we'll illustrate this in this slide here, showing the different targets for the antithrombotic drugs, aspirin blocking thromboxane A2 release, P2Y12 inhibitors blocking P2Y12 receptors, and anticoagulants acting on thrombin indirectly or directly, which not only inhibits coagulation but also inhibits platelet activation. So the anticoagulants are having a direct or indirect antiplatelet effect, and that's important when we're speculating about the potential efficacy of anticoagulants in preventing stent thrombosis. So the next question relates to clopidogrel, and here we have a range of options. Number 1, or A, clopidogrel binds reversibly to platelet P2Y12 receptors. 2, or B, it is a reliable prodrug with consistent antiplatelet effect. C or 3 relies on hepatic conversion to its active form for antiplatelet effect. 4 or D has similar potency to prasugrel, and 5 or E is absorbed from the stomach.
And isn't that something that has kept us busy over the last couple of years? And it's interesting, you know, that to see how variable at the end of the day. And I don't want to give the question away how variable effects of some of the P2Y12 inhibitors may be, and then you do the large studies, and you ultimately on a population level don't find that much of an effect for testing and for adapting your strategies, right? It's interesting. Well, let's see what people answered. So here there's a split, Rob. There's a split between number 1 and number 3. So 33 to 36% either say it binds reversibly to platelet P2Y12 inhibitor, or 3 relies on hepatic metabolism for its antiplatelet effect.
Very good. So, well, it binds irreversibly, or at least the active metabolite of clopidogrel binds irreversibly to platelet P2Y12. That's why recovery from the effects take up to 10 days as the platelets are replaced. And correct, it relies on hepatic metabolism. And it's not a reliable prodrug because of the variability in the activity of those hepatic pathways between individuals, which leads to very different levels of active metabolite formation between individuals. It's not absorbed from the stomach, it's absorbed from the intestine, which is relevant to effect of morphine, which delays the absorption of all the P2Y12 inhibitors, in contradistinction to aspirin, which has some absorption from the stomach. And we see on this slide how clopidogrel, before it can get to the liver, much of it is wasted by conversion to clopidogrel inactive metabolite. And that's why clopidogrel varies in its potency between individuals because of differential rates of inactive versus active metabolite formation. Now we show the variability to clopidogrel in these studies. On the left is comparing ticagrelor with placebo, 2 different maintenance doses, pre and post maintenance dose compared to placebo of ticagrelor 60 and 90. And on the right, comparing those same maintenance doses of ticagrelor, this time with clopidogrel using the same assay. And what we see in this when we compare the 2 studies is there's a big overlap between the effects of clopidogrel and placebo. Whereas ticagrelor's effects are well differentiated from placebo. The flip side to this is that about 30% of clopidogrel-treated patients have a similar level of platelet inhibition to patients treated with ticagrelor. So you get high responders to clopidogrel just as you get poor responders in a similar proportion. And so this makes it unpredictable when you give clopidogrel what response you're going to get. And that dictates both the bleeding risk and the risk of ischemic events, including stent thrombosis. Now, it's important to remember that these P2Y12 inhibitors, even a potent one like ticagrelor, doesn't have so much effect on bleeding and hemostasis when used by itself. We see here bleeding time with ticagrelor versus no antiplatelet treatment in healthy volunteers. It's only when you add aspirin to that you get this more profound effect on hemostasis. So it's when you combine P2Y12 inhibitor and aspirin that you get the most effect on hemostasis. And that's relevant when we're considering some of these combinations. So we don't have up-to-date guidelines on ACS following the Augustus study, but we did have the recent released chronic coronary syndrome recommendations. And we can take some potential messages from this, or perhaps a steer on where things may go in the future with guidelines on ACS. But here we recommend, after uncomplicated PCI, early cessation of aspirin within 1 week and continuation of dual therapy with oral anticoagulant and clopidogrel should be considered if the risk of stent thrombosis is low. And we could perhaps argue about how much risk is associated with ACS and whether it's all ACS or different sort of spectrum within that. But you can also consider this dual therapy approach with early cessation of aspirin if concerns about bleeding risk prevail over concerns about risk of stent thrombosis. So 2A recommendation there. Whereas with triple therapy with aspirin, clopidogrel and oral anticoagulant for 1 month or more should be considered when the risk of stent thrombosis outweighs the bleeding risk. The total duration, maximum of 6 months, less if possible, decided according to the assessment of the risks of stent thrombosis, bleeding. and specified at hospital discharge. What about the potent P2Y12 inhibitors? Well, here the message is that dual therapy with an anticoagulant, preferably a NOAC, and either ticagrelor or prasugrel may be considered, so 2B, as an alternative to triple therapy with anticoagulant aspirin and clopidogrel in patients with moderate or high risk of stent thrombosis, irrespective of the stent type used. However, the use of ticagrelor or prasugrel in triple combination is not recommended because we know that carries too much bleeding risk to really be supported. So here was the management decision in this case, so opted to continue ticagrelor for 6 months, if tolerated, and then stop it, at the same time as stopping aspirin immediately after PCI. But continue apixaban 5 milligrams twice daily, long term. And in this case, it was a bit in the balance in terms of ischemic risk, coronary risk, and bleeding risk. But in this case, it was decided after 6 months to continue just with apixaban monotherapy because of some of the concerns about the bleeding risk factors. And in terms of progress, so we did have 2-year follow-up in this case, and the patient remained free of thrombotic or major bleeding events.
Terrific. Well, thank you very much, Rob. That very, very instructive case. A question to Robert Byrne. Would you have done the same thing if you take a look at the management of that patient? Would you have gone and left off any type of antiplatelet therapy 6 months after the event?
So I think when we get out to 6 months, I mean, you showed nicely in your presentation that we're having a lot of data that's emerging and helping us to decide what to do in the initial phase after ACS and in the initial phase after PCI. But what we do after 6 or 12 months is not as well investigated. And the guidelines changed around 4 or 5 years ago and recommended in these patients who are on OAC that we think about leaving away antiplatelet therapy over the long term and just leaving them on OAC. So I can understand why Rob made this decision in treating this patient. We have had some randomized trial data emerging at ESC, the EHRA trial, which looked at Asian population and looked at dosages of drugs that we don't use in Europe, but seemed to provide further support for the concept of monotherapy with oral anticoagulation after the acute phase, maybe 6, maybe 12 months has passed. So I think I would broadly support what Rob did here regarding the long-term treatment.
That's interesting, right? Because we had those data for vitamin K antagonists for a long time. I mean, vitamin K antagonists are actually quite efficacious in acute or in chronic coronary syndrome patients, right? We've known that for a while, actually from the pre-stenting era even. But we've never had that up until the EHRA came out. We never had that for NOACs, right? So I think it is, I would fully agree. I think this is a good step ahead.
Yeah, I think it is an area where we'd like to see more data, and a European trial done in large numbers, powered for ischemic and bleeding endpoints, I think would certainly represents an unmet need.
Yeah.
I think 12 months is starting to look a bit arbitrary because we know from 6 months onwards the risk, is either very, very low, or if it's increased, it remains there sort of long term for many years. So I think we are sort of getting to an approach where you either sort of cover the period of stent healing or you consider sort of longer term, more intensive therapy because of higher ischemic risk, which tends to be enduring.
Absolutely. Speaking of higher ischemic risk, we'll move over to Robert Byrne's presentation, and after non-STEMI, we'll shift gears into a STEMI case. Robert.
Yeah. Well, thanks, Jan. A pleasure to be here. And I'm going to show a case, like you mentioned, also an ACS case, but perhaps at a different end of the spectrum. Some similarities to what Rob showed, but also some differences. So these are my disclosures. So the case that I've brought is a recent case from Germany before I changed institution in the last number of weeks. A 72-year-old patient presented with acute chest pain, continuous retrosternal pain, abrupt onset, lasted 2 hours. The prior history is remarkable for known coronary disease, requiring revascularization, PTCA stenting in the RCA in 2003, PTCA stenting in the LAD in 1995, with bare metal stents in all cases before widespread availability of drug-eluting stents. Risk factors, hypercholesterolemia, positive family history. As regards the general medical history, nothing extra particularly of note. The eGFR was 75 mils per minute and the weight is 85 kilograms. I'll show you the ECG in a moment, and an echo, just to give overall orientation, showed a posterolateral hypokinesia with a EF of around 45%. This is the ECG and on presentation, and you can appreciate, I think, ST elevation in the inferior leads in 2, 3, and AVF with evidence of Q waves. If you look at the precordial leads, you will also see some ST elevation in V6. So the impression was of an acute ST elevation myocardial infarction.
And just in case somebody's wondering, this guy is not severely bradycardic. This is 50 millimeters per second, as they usually do in Germany. And he also doesn't have a huge first-degree AV block. Okay.
Yeah, important to note. So at this stage, I think the diagnosis was established, ST elevation myocardial infarction, and it wasn't a difficult decision to acutely activate the catheterization laboratory. And the question that I have for you in the audience is, what antiplatelet therapy would you recommend at this time point while waiting for the catheterization team? So I've brought 4 options, and these are: number 1, aspirin and prasugrel. Number 2, aspirin and ticagrelor. Number 3, aspirin and clopidogrel. And number 4, aspirin and clopidogrel, but adding a glycoprotein receptor antagonist.
All right, excellent. And again, while we're waiting for the answers to come in, Rob, GP2B3A inhibitors, do you still use it? When do you use it?
So we only use them, or have been using them, in patients who've received morphine at the same time as they're loading with P2Y12 inhibitor. And that's because we know that the morphine delays the onset of action, and we've actually published our data showing that reduces the risk of acute stent thrombosis if we target those patients. But otherwise, we just give a 6-hour infusion of tirofiban, and we don't sort of prolong it, because then that's unreasonable bleeding risk. But other patients, we tend to move away from using GPIs and just use the potent P2Y12 inhibitors, ticagrelor or prasugrel.
Well, Dr. Byrne, here's a challenge for you. Over 50% of our audience feel that number 2 would be their choice, aspirin plus ticagrelor.
Yeah. Well, I'll tell you what we did. I mean, first of all, picking up on what Rob says about glycoprotein receptor antagonists, I think there's been a move away from this in general in recent years. And this is something we mainly reserve, even in a STEMI setting, where you might be more liberal, for a bailout scenario if you have problems during the intervention with recurrent thrombus formation. So we tend not to give GPI upfront anymore. Our choice in this patient was a recently encountered patient, was to give aspirin and prasugrel, and I'll show you why we made that choice. Influencing our thinking, of course, was the ISA React 5 trial, which also was recently presented. This was the first study, the first large-scale study, I should say, comparing ticagrelor and prasugrel head-to-head across the spectrum of ACS patients with STEMI and non-STEMI that had gone to completion. And the primary endpoint was a composite of death, myocardial infarction, or stroke. And actually, we hypothesized that there would be a benefit for ticagrelor over prasugrel. Now, what we found, you can see on this slide, was actually an increased hazard of the primary endpoint with ticagrelor. 1.36 is the hazard ratio, 9.3% against 6.9% with prasugrel. And this was could be interpreted as a statistically significant reduction with prasugrel, superior to ticagrelor in terms of antithrombotic efficacy, which really was somewhat of an unexpected result for us. When you look at bleeding and look at the safety endpoint, which was really major bleeding, BARC classification 3 to 5, actually we didn't find a difference, and maybe we can discuss the reasons for this afterwards. You can see 5.4% with ticagrelor, 4.8 with prasugrel, so if anything, slightly lower with prasugrel, but broadly similar bleeding risk with both of these treatments. So I think we've started to incorporate these results in our practice, and for this reason, in a ST elevation myocardial infarction patient in particular with high thrombotic risk, we would preferably treat this patient with prasugrel, although the guidelines at the moment would give a class 1 recommendation for both ticagrelor and prasugrel. So we proceeded then to coronary angiography, and here you can see quite severe disease really in the left anterior descending and the diagonal branches, and also in the circumflex disease. Circumflex posterolateral branch also disease. And here is the right coronary artery, which revealed the culprit lesion and an abrupt vessel occlusion with dye hang up in the distal right coronary artery. So we proceeded to recanalize the right coronary artery and sequentially dilate with non-compliant balloons, and successfully restored flow, as you can see here in the right-hand picture. Because it was a case of stent failure, and I realized that maybe from the angiographic projections here on your screen you might not be able to realize this, but it was the abrupt occlusion appeared to be in the stent area. We did an OCT after establishing flow, and here I think it's quite interesting. You can see, if you look at the longitudinal pullback at the bottom of the screen, we've highlighted 3 sections, and just at the beginning of those sections at A you can see this flap of tissue. You can see it in panel A in the left upper quadrant, that there was quite a marked neointimal flap. Now, it's difficult to know in these situations how much is due to the angioplasty they've just done to re-establish flow, and how much is due to perhaps a ruptured plaque inside the old stent, which you will recall from the history had been present for quite a long time. But if you look downstream at the end of the stent, and we've highlighted that in segments B and C, you can see evidence of thin cap fibroatheroma, and this is consistent with what we know about bare metal stents. Late after implantation, they tend it's not infrequently they get neoatherosclerosis forming, and this was probably a ruptured neoatherosclerotic plaque which led to the acute stent failure in this case. We then proceeded to stent implantation, seeing this considerable flap inside the old stent with a 3023 new generation drug-eluting stent. And you can see in the OCT control straight after stent implantation really quite a satisfactory result when you look at the longitudinal and cross-sectional views, though you will notice that the stent expansion index comes out at about 0.68, which is maybe a hint that we could have more acute stent expansion. We'd like to aim for 0.80, 0.90 as an expansion index immediately after the procedure. And we did go back in and dilate with 3.5 non-compliant balloon at 17 atmospheres. And here I think you can see an acceptable angiographic final result. So back to our patient then, a 72-year-old patient with STEMI, settled well initially in coronary care, and a staged PCI was planned to the LAD. However, the patient did develop mild signs of pulmonary congestion and was started on intravenous diuretic therapy, and on day 2 developed atrial fibrillation with rapid ventricular response and was initiated an IV anticoagulation. The patient failed to respond adequately to pharmacotherapy, underwent transesophageal echocardiography and cardioversion to sinus rhythm. So the next question that I'd like to ask you is, how will you manage the antithrombotic therapy at this point? So we have treated the patient with aspirin and prasugrel, and the 4 options that I've brought with me are: number 1, continue the DAPT as is and add NOAC. Continue the DAPT, but de-escalate from prasugrel to clopidogrel and add NOAC. Discontinue aspirin, staying with P2Y12 monotherapy, add NOAC, or discontinue the P2Y12 inhibitor and add NOAC.
Yeah. So these are 4 out of the, 2.8 possibilities that we have, right? That's what C. Michael Gibson always comes up with. But I think 4 pretty reasonable ones. Okay. So let's see. So the majority would go with number 2. Continue DAP, but de-escalate to clopidogrel and add NOAC. What you guys do?
So that was our impression too, actually, and that's what we did in this patient. We decided that we wanted to continue the patient on triple therapy, so we needed both DAPT and NOAC, but we were uncomfortable with combining the more potent ADP receptor antagonists as part of triple therapy for the reasons that you outlined. It is a Class C recommendation, should be avoided where possible. We had some data from our centre showing really quite a significant bleeding risk in those patients who were tripled with a more potent ADP receptor antagonist. However, we decided we weren't happy to keep the patient just on P2Y12 monotherapy, and for this reason then we de-escalated from prasugrel down to clopidogrel.
However, I do notice that you had adding a NOAC in all of your choices, and I think this goes to a question that's been put up a couple of times already here now. Should we treat a fib that comes up as the first manifestation during such a situation, like paroxysmal AFib or pre-existent AFib, or should we consider this sort of as secondary atrial fibrillation? What's your take, Rob?
Well, I think, this case is a bit different to the patient who presents in AF with their STEMI and it resolves immediately. You open the artery. But even in those cases, there is sort of recommendations that is an indication for anticoagulation. But this case is a bit different because they've developed AF in the context of heart failure. Patient's got a high risk of left ventricular thrombus as well as recurrent AF after the cardioversion. The heart failure increases, the risk of thromboembolism further. So no doubt in this case that this patient needs long-term anticoagulant therapy. And Class 1 recommendations for NOAC rather than VKA in a patient like this.
I would fully agree. I mean, this is a 72-year-old patient. We're not talking about a 35-year-old patient, otherwise healthy, who has a fulminant pulmonary embolism or a thyrotoxicosis. I think in general, we tend to be very careful with the definition, with that diagnosis of secondary atrial fibrillation, especially in those at-risk patients. This very frequently is paroxysmal atrial fibrillation that just manifests for the first time during such a situation, right?
Yeah. I mean, I think these are situations that we encounter in clinical practice. These are situations where we don't have data that's really classically derived from randomized clinical trials. We have to extrapolate a little bit from the randomized trial data that we have. And we thought, on balance, you're going to require triple therapy. The bleeding risk is substantially lower with NOAC as compared with a vitamin K antagonist. And I think the decision for NOAC was an easy one at this stage, in our opinion.
I'll just pick up this point about de-escalation to clopidogrel. So on a population basis, if you switch from prasugrel to clopidogrel, you are de-escalating. But in an individual case, you won't necessarily de-escalate because you may have a prasugrel-like response on clopidogrel if they're one of the 30% who are high responders to clopidogrel. So again, this sort of points to sort of difference between treating individuals and populations, and clopidogrel is a difficult drug to individualize with. Because of this variability in response.
Yeah, and I think we saw that quite nicely in some of the data you showed earlier, where we saw the overlap between both the placebo response and the more potent ADP receptor antagonist when you looked at platelet reactivity.
I think that's a very important point, Rob, and similar what you're saying. Ultimately, I think I probably would have gone for the same, with that caveat that you don't know if you're really de-escalating. But given that the majority of the data from those 4 trials really are based on clopidogrel, not and few on ticagrelor, the fewest actually on prasugrel. I would probably go with the same, but obviously keeping in mind that this may also result in a very similar platelet reactivity as with prasugrel.
Yeah.
Terrific.
So one of the issues, of course, that we considered, and I mentioned it and had it as one of the options, is could you de-escalate straight away to a P2Y12 inhibitor monotherapy combined with the OAC? And I told you that we had some concerns about that. Now, when you look at the data from the randomized trials, and I suppose initially, as regards these patients, we had 2 investigator-initiated studies, which were WUST and ESAR triple, relatively modest size. But like you showed in your introduction, we've now had 4 large-scale randomized trials with the NOACs, which have looked a little bit more at dual versus triple therapy. And this is just a summary slide that I brought based on the crude counts of events across the first 3 NOAC trials. So it didn't include Entrust and WUST. ESAR triple I didn't include because this is both arms had some duration of triple therapy in that. And what you see, broadly speaking, is an important reduction in bleeding with dual therapy that doesn't come as a great surprise, with a less potent against more potent antithrombotic treatment strategy. But I think many of these trials had liberal bleeding definitions for reasons of power. So it's important to dig down and really just look at major bleeding, for example, BARC 3 to 5 bleeding. And you do see in terms of major bleeding a significant reduction. So I think that's clear. What you also do see, however, is a slight increase in thrombotic events. And this doesn't reach statistical significance, but you can appreciate a visual trend, more stent thrombosis, more myocardial infarction. And if you look at overall death as an arbiter of net clinical outcome, certainly you're not seeing a strong signal one way or the other. So I think there is room for both dual and triple therapy, broadly speaking, in these patients.
I fully agree. And I think this is one way in which these trials have been misinterpreted in my eyes, because we're kind of coming from that notion, which is backed by a lot of data, especially from the phase 3 NOAC trials versus warfarin, that major bleeding is a bad thing and which is driving mortality. We've seen this in the ENGAGE in particular, but also in other trials. This does not seem to be the case here, because although there is, like you beautifully show here, there is an increase in major bleeding, death, if anything, goes in the other direction. So we're primarily talking about access site bleeding, some of it which can be taken care of by going with radial rather than with femoral and all that. So it does seem to be a different, I wouldn't say a different ballpark, but definitely a different game here than what we're used to. So the case fatality of the bleedings that we're seeing here does not play out the same way as in the large phase 3 trials, right?
Yeah, I think the relationship between bleeding and mortality is so hugely complex, and it is confounded because, for a start, patients who bleed are more likely to, at higher risk anyway of ischemic events. It's how you handle the bleeding is important, and the Working Group on Thrombosis issued a position paper on exactly that topic, urging people not to be overactive in stopping or prolonging cessation of antithrombotic drugs, because you get a pro-inflammatory response to bleeding that means that that's when you really need your antithrombotic drug. So many different factors here. But I think it is important to stress for the overwhelming majority of patients, the risk of dying from a thrombotic event is much greater than the risk of dying from bleeding.
Mm-hmm. I mean, when you look at these trends in terms of stent thrombosis and myocardial infarction, certainly you can say for patients that are at heightened thrombotic risk because they're STEMI, because they're a stent thrombosis, I think we should be cautious of dual therapy from the outset in these type of patients. Now, we did look a little bit in meta-analysis, formal meta-analysis, after the Entrust data became available. And without going into too much detail, you will see the point estimate for myocardial infarction increase indicates an approximate 21% increase in the risk of myocardial infarction. And if you look at stent thrombosis, you're seeing a similar picture. Actually, here the point estimate is a little further to the right, showing benefit with aspirin as regard to without aspirin. And if you look in a little bit more detail, you will see that the WUST trial is a little bit of an outlier for one reason or another, where there tended to be more thrombotic events in the patients who had triple therapy. And actually, if you leave those patients out, what you're seeing is an increase in the risk ratio up to 1.47, and it looks just about statistically significant. So these are relatively low frequency events. However, at the same time, I think this data should play a role in influencing our management of patients, particularly where we think there's high thrombotic risk. So, of course, the next question is, how will you handle the switch of P2Y12 inhibitor? Because if you've said that we've started now with Prasugrel and we want to change, I won't say de-escalate in this patient's case in particular because we don't know, you want to change down to Clopidogrel, how will you do this? There is some guidance available, and I think the focused update on DAPT, which was initially published in 2017 from Marco Valgemilli, went into a little bit of detail and gave us acute settings and chronic settings. To make it easy, in the acute setting, reloading is always required. And you can see this is a patient who was on Prasugrel, and there's a recommendation in those patients to load with Clopidogrel 600 milligrams 24 hours after the last Prasugrel dose. So I think that's how we would recommend to handle the issue in this patient. So the final question then that I brought as regards to this case of a 72-year-old patient with ST elevation myocardial infarction due to a stent thrombosis in the distal right coronary artery with residual disease in the LAD, which remember will also require treatment, is what is your antithrombotic therapy? What will you plan for the first 6 months? And I've brought again 4 different treatment options, and I'd ask you please to vote. Option 1 is NOAC, aspirin and Clopidogrel for 6 months. Option 2 is NOAC, aspirin, Clopidogrel for 3 months. Option 3 is NOAC, aspirin, Clopidogrel for 1 month. And option 4 is NOAC and P2Y12 inhibitor monotherapy for 6 months. So again, maybe 2.8 million different permutations, but these are 4 that we thought were reasonable, and we'd ask you to vote on these 4.
And we're getting there, we get 4, another 4, and, we're moving our way up. But it's true. And it's not an easy question, like you're saying, because, we have a lot of data now comparing dual versus triple, and certainly from Augustus, the largest of those trials with the 2x2 factorial design, probably also the most robust data in that regard. But for the duration of triple therapy, triple versus dual with NOACs, this is still an area where we are a little bit, where we have to rely on our clinical judgment and put everything in together, right? And so this is why I guess it comes at no surprise that although a majority, 37%, would go with option 1, around about 20% also go with option 2 or 3, and 17% with option 4. I think that's very well reflective of exactly that. So what you go with, Robert?
Yeah, I think so. I mean, we did have the same opinion as the majority out there, and we thought this is a patient who has a stent thrombosis, who also has critical disease in the LAD. And Rob showed nicely earlier on, we talked about it, when you're looking at risk of stent thrombosis, you want to look at the risk and the consequences of stent thrombosis. So I think of all the risk factors for stent thrombosis that we're aware of, probably having had a stent thrombosis is the strongest risk. And this is a patient who's proven himself to be a stent thrombosis risk patient. And that's why we were tending towards the longer end of the spectrum with regard to triple therapy towards 6 months. And that's what we recommended in this patient. If you look at the most recent guidelines on myocardial revascularization from 2018, they provide a general algorithm for your duration of dual antiplatelet therapy. On the left here are stable patients, on the right acute coronary syndrome, which is the topic of today's webinar. And then you should further look in ACS and stable patients at what the bleeding risk is. And I think patients requiring oral anticoagulation automatically belong to the high bleeding risk patients. And in these group of patients, I think in acute coronary syndrome, there is a weak recommendation, a class 2 recommendation for a 6-month duration of dual antiplatelet therapy, which is in line with what we did. So I think our impression is the totality of the clinical evidence. When you look at the investigator-initiated trials like WUST and ICER Triple, when you look at the large NOAC trials that have become available in the recent year, is that there's probably no one-size-fits-all. There's a strong rationale for individualization of therapy, with bleeding risk predominating a short duration of triple, or probably even dual therapy, where the ischemic risk predominates, then a longer duration of triple therapy out to 6 months. And I think longer than that nowadays isn't usually an option. And a personalised approach like this, I think, is supported by the current clinical practice guidelines, which may well change as we move forward, taking into account the data that's recently become available.
All right. Mm-hmm. Terrific. Well, thank you very much, Robert, for this excellent and very instructive, like yours, Rob, case presentation. There's a couple of questions that are coming in, as we would assume. Actually, quite a couple of questions coming in, and one of them relates exactly to what Robert was mentioning in the end, right? Because there's a very good chance that guidelines will change. There's a good chance that our new iteration of the EHRA Practical Guide might be adapting to this. Would you wait until these guidelines change, or would you change your clinical practice now?
I think this is always a challenge with managing individual patients. You know, you have to make a decision there and then. You can't wait for the guidelines to decide what to do. So I think, my practice has been sort of evolving over the years, but still very much based on individualising with the patient I've got in front of me, weighing up the balance of stent thrombosis risk, stroke risk, and bleeding risk. Augustus now gives us the confidence to use a full therapeutic dose of NOAC in these patients. That's well characterized now. So I'm happy to do that, to use a full dose NOAC, and then base my sort of decisions on antiplatelet therapy around that. And I think, the other thing that Augustus gives us is really tells you the magnitude of risk that the patient faces when you give triple therapy. Whereas the risk of stent thrombosis is a bit more uncertain, particularly when you're sort of using a potent P2Y12 inhibitor with a NOAC. There's a lot of uncertainty there, but we know that if you give aspirin in a triple combination, it sort of drives a much greater bleeding risk. So that's a sort of challenge. But I think, as time passes, I'm getting more confident with stopping aspirin early. Tending to use a potent P2Y12 inhibitor in those in whom I think the risk of stent thrombosis is manageable. So I wouldn't obviously do that in a left main bifurcation stenting procedure, but in the patients like that sort of beautiful example that Robert showed of a fantastically implanted stent with OCT evidence, in that case that it's really well deployed. With thin strut stents, they sort of seem to cover over quickly, and the stent thrombosis risks of declines very quickly, and even following the procedure is, very low. So I think, I think we are moving in that direction, and I think that allows, really relies on an appreciation of the role of thrombin in platelet activation.
I think, the question, do we wait for the guidelines, is a good question, because I've told you in my presentation, as regards prasugrel versus ticagrelor, when a patient comes in with STEMI, we maybe look at the trial data and say, this is a patient I would treat with prasugrel rather than ticagrelor, even though the guidelines give both classes of age, both drugs a class 1 recommendation. So I think, we evaluate as physicians not only the guidelines, but the emerging clinical trial data. With dual therapy, we've seen a lot of data for dual therapy, and the only point I would caution is if you do think a patient is eligible for dual therapy, maybe don't leave aspirin away right from the start. If you look at Augustus, for example, the median time from the index event until enrollment in the trial was around about 6 days. So there probably is, even for dual therapy patients, and I'm not saying the patient I showed is a dual therapy patient, but probably you do need a period of some triple therapy, be that 6 or 7 days.
Yeah. Absolutely. So terrific. Well, we still have a lot of questions here, and we have 5 minutes left. So I suggest we do a kind of a rapid fire session for the final couple of minutes here. And here's a good question to start for a quick answer. Any preference for any of the NOACs in that context?
So I do have a preference for twice daily dosing versus once daily, because when you're combining with antiplatelet therapy, you want to smooth out the sort of 24-hour profile and not get too much peak trough effect. And that's particularly, if you're using dual therapy with Clopidogrel, and there may be no response to Clopidogrel, you don't want to have a period where at any time during the day where you've got no antiplatelet effect and sort of very low 10A levels. So that's my sort of preference, really.
Yeah, I don't have a strong preference. I think what you're used to dealing with, what you're used to dose adjusting with, probably would be my recommendation.
Yeah, I kind of go with that as well. Actually, I would say there's now 4 trials out there, and although I've had a very similar feeling with respect to that, ultimately the pioneer and also interest at the end of the day, really in terms of, I mean, these are not tens of thousands of patients, like none of them are, but they did not show a clear signal in my view, in the sense that you lose really efficacy in terms of absolute event rates. I would also rather go for, I think there's room for individualization also on the NOAC side, and I think whichever NOAC fits best to that patient, I would probably recommend to go with. And there's a lot of things factoring into that: age, renal function, and what have you. And so I think that probably makes sense. In that context, any reservations towards the bigatran? There's always been that signal or that hint of a signal that there may be an issue in terms of myocardial infarction with the bigatran, with a thrombin inhibitor rather than a 10A inhibitor. Let's start with you this time, Robert.
Yeah, well, we saw it in the 110 milligram group that received dual therapy in ReDual, that there was a signal towards increased stent thrombosis, a signal towards myocardial infarction. Probably wasn't as clear with 150. So there are some concerns there, I would say.
Rob?
Yeah, likewise. I mean, obviously, it's a different class of anticoagulant to the 10A inhibitors, and there has been that signal. So I think that's sort of, I have some concerns about that.
I think if you feel strongly for the bigatran, probably going with the 150 milligrams dose would be a good idea. But then again, have to keep in mind that in RELY, of course, there was the age interaction, especially with respect to bleeding. So I need to keep that in context.
It's a difficult one. I mean, there is some concern there. We saw also increased thrombotic signal also in Augustus. So, I mean, it's a difficult one to tease out. If the patient came in on dabigatran, I mightn't want to change them away from it.
Yeah.
Okay. I agree. That clearly would be a problem, because you don't want to switch from a direct thrombin inhibitor to a sort of anti-10A inhibitor because of the sort of risk of interaction when you sort of switch them over.
Yeah. Which types of patients do you actually keep an antiplatelet agent above and beyond the 6 or 12 months? So which ones do you not keep on NOAC monotherapy? Let's again start with, I don't know who started first.
Yeah.
I mean, so we did sort of cover that in the chronic coronary syndrome guidelines, in terms of it has to be quite a select group of patients who have a very high risk of long-term sort of ischemic event risk, but without conditions associated with increased bleeding risk, which includes anemia, as well as some other sort of bleeding risk conditions. So they tend to be sort of those with extensive multivessel disease, perhaps PAD as well, or diabetes, CKD, those sorts of unmodifiable risk factors. So they'd have to be a select group of patients with a very high ischemic risk and without bleeding risk conditions.
Yeah, I broadly agree. I'm thinking prior stent thrombosis. I'm thinking stenting of last remaining vessel, left main stem, bifurcation stenting, assuming that, of course, the bleeding risk is not exceptionally high in these patients. They would be the ones that I would tend to leave on monotherapy antiplatelet with the OAC.
Okay. Terrific. Nothing to add here. What if they have to undergo surgery in the first 3 to 6 months after such a situation?
So I think that's one. I mean, we all know that's a phone call we probably receive very often in our practice. Somebody ringing an outside line, what do you do with these patients? I think with the NOAC, you will take the risk of stopping the NOAC for the procedure, assuming that it's an urgent procedure. And then we tend to say, leave the patient on aspirin. If at all possible, operate the patient on aspirin. And the ADP receptor antagonist, then we'll say it depends which one it is. 3 days if it's ticagrelor, 5 days if it's clopidogrel, and 7 days if it's prasugrel. I mean, that's our basic recommendation when we get these calls.
And then we said it's a rapid fire. We could easily discuss for half an hour about that topic alone. Rob, anything to add to that?
Just that you can use platelet function testing for when you come off clopidogrel, because you don't know whether they're high or low responder, and that can help sort of dictate the time to surgery.
Okay, terrific. Yeah, well, I guess, unfortunately, we're really running out of time. But I would have another 10 questions here, but this has been a lot of fun. But we are approaching the end of this webinar, and I'll have to close this, unfortunately. But I'd like to briefly summarize the key messages for your daily clinical practice. I think number one, these patients post ACS stenting are a high risk subgroup of patients. They have a risk of ischemic events that is higher than in somebody with a chronic coronary syndrome, although we also know that these patients have a residual risk that is relevant, but these patients obviously have a higher risk. Number two, NOACs are safe and effective also in this setting. This is something that 10 years ago, when we entered the era of NOACs, we didn't know that. Now we do know that we can rely on NOACs also in this setting, and this is certainly one of the things that these 4 trials have given us as data. Third, the optimal duration of triple therapy is getting shorter and shorter. In the past, we used to say, well, just give them triple therapy for a year. These days are over. These days are long over. The optimal duration is currently unclear. I think we talked about this, and especially with respect to that, but also with respect to the choice of the NOAC, also with respect to possibly the choice of the P2Y12 inhibitor, individualization makes absolute sense in that setting. There is no, as we've mentioned several times, there is no one-size-fits-all solution in these complex scenarios. So makes sense to take a look at this in detail. It is a complex topic, but it's worthwhile investing time into because we ultimately will have an impact on our patient care. So with that, I would like to thank you both, Professor Byrne, Professor Story, for being here, for your terrific presentations. Thank you very much.
Thank you.
Thank you.
And again, this webinar was supported by Bristol Myers Squibb and the Pfizer Alliance in the form of an unrestricted educational grant, and the program is not influenced in any way by its sponsors. You'll be able to watch this webinar on demand on the ESC website. And that was it for today. Thank you very much for watching, and have a good night.